Hello, everybody. I'd like to welcome you all to this World Ovarian Cancer Coalition session on the socioeconomic burden of ovarian cancer in 11 countries. My name is Mikis Euripides, and I am the study lead. I'm going to take you through some slides that goes through the methodology, approach, and results for this study, which we hope to have published early in 2025. As you can see, it's a collaboration between ourselves, the World Health Organization, and RTI International Center for Non-Communicable Diseases. Just a little bit about the background of the study. It's the first multi-country study reporting the socioeconomic burden of ovarian cancer at national level, and it quantifies the annual burden to patients, caregivers, health systems, and the economy. So quite a broad study. We included 11 countries as part of the study, which were a mix of high income, middle income, and low income countries. And essentially, we're providing insight to the extent to which the burden differs across those countries and also how they differ in terms of the income level of those countries. We're doing this to support advocacy for our partner organizations, particularly in low middle income countries where locally relevant data can be, obtaining that data can be a struggle. So the approach that we took, as I mentioned earlier, this is an attempt to quantify the annual, so the 1 year socioeconomic burden from the perspective of patients, caregivers, health systems, and the broader economy. And as part of this, we include what some people might say traditional cost of illness approach. So that includes the direct medical costs for the health system in each of those countries, costs such as medications, the cost of hospital visits, right across the care pathway. But it also includes non-medical costs such as patient time. So we define that as the time taken by patients to travel to receive care and the actual time that they spend receiving that treatment for ovarian cancer. There's also the indirect costs as part of this study, so labor force productivity losses due to cancer attributable absenteeism, presenteeism, and labor force dropout, and also the informal caregiving aspect. And in terms of quantifying or monetizing all of this, we use the value of lives lost based on the value of a statistical life year. Essentially, this is an approach which uses individuals' willingness to pay for small changes in mortality risks to assess how much societal value is gained in each life. And what we do is we attract the years that women would have lived based on UN projections and assign a value, if you like, to those costs. So in terms of some of the data sources we use, I mentioned earlier the care pathway or care continuum. We had a starting point that we had to assign across all of the 11 countries, just to emphasize this is not an individual cost of illness study focusing on each individual country and each individual circumstances. We had to apply a care continuum that was used for all those 11 countries, a single care continuum, but we did adapt the costs that were and data sources that were available to us as much as we could in terms of country level data. So that care continuum, we use the NCCN guidelines for ovarian cancer from 2023. In terms of the actual numbers, incidence, mortality data, we use the most recent IARC Globocan statistics for 2022, which were published earlier this year. We collaborated with the WHO Cancer Control Program. We use the WHO choice outpatient and inpatient cost estimates. And there was also studies such as the Concord 2 study, which, as many of you know, provides data on international cancer survival rates. The economic databases that we used included the World Bank information, which provides GDP per capita, the International Labour Organization, which provides average earnings for all countries, including minimum wage rates, and also the UN Population Division, which provided the demographic parameters calculating survival probability, which I mentioned earlier, which allows us to place a value or cost on the lives that women would have lived and what their contribution would have been. We also had the benefit of using the Every Woman Study data. So not only the high income edition, which was published in 2018, but also the ongoing yet to be published Every Woman Study LMIC edition. This provided us with really valuable insight where perhaps we would not have been able to tap into the information when it comes to things like patient time spent traveling, treatment, the genetic testing aspect of it in terms of how many women were actually getting tested and so on and so forth. So that provided us with a really rich source of data. There were also a number of national databases, which I mentioned, I touched on briefly earlier. I've got some examples there, including the American Hospital Association, which provides medical equipment costs, and so on when it comes to actual direct healthcare costs. When it comes to medication costs, we would use things like the drug database, but also the WHO very usefully provided costs for medication costs when it comes to their own databases. So this is an infographic that we produced that we recently showed at the UICC, where we presented the interim results of this study. So as you can see there, it captures the total cost for all the 11 countries. So you can see the different countries part of the study here. I mentioned a mix of high income, middle, and a single low income country, that was Malawi. You can see here the total socioeconomic cost is 70 billion US dollars. So this is 2022 US dollars, the vast majority of which is taken up by the value of lives lost, that women who would have lived, how they would have contributed to society. And these are the different cost categories here. So you can see in terms of direct healthcare expenditure, that amounts to 5.2 billion US dollars for all 11 countries. And I'll go back to some of these in a moment. The other cost categories, the patient time, again, which I touched on earlier, so divided into two, travel time and treatment. So you can see here the equivalent of 3,663 years annually, or 18 work days per woman in terms of the cost, and we monetize that based on average wage rates. Then we have the labour productivity losses. So you can see absenteeism, that is being absent from work on account of your ovarian cancer, presenteeism, being present at work but being less productive, and then in terms of labour force shortfall, so dropping out of the workforce altogether. And then we have the informal caregiving costs, so the individuals, those family members, perhaps friends or close friends, the time that they spend looking after women with ovarian cancer. This as a policy issue has gained a lot of traction over the years, and what we've done here is we've monetized that based on minimum wage rates in each of the countries. So again, I'll touch on some of these others in terms of the average socioeconomic as a percent of GDP, for example, is 0.11%. So the total gross domestic product of a country, of those 11 countries, the average is 0.11%. In terms of healthcare expenditures alone, so this area here, this 5.2, 70% of health expenditure is taken up by maintenance therapy. On average, 27 workdays are spent traveling to and receiving treatment in the first year post-diagnosis of ovarian cancer. And just a couple of notes here in terms of the productivity losses. So that's only measuring women living with ovarian cancer, not those who died. And that amounts to, and in terms of informal caregiving, finally, that's 33 days of caregiving, which reflects that some women don't actually receive this care. So in terms of some of the differences between the countries, in terms of, as I mentioned, the high-income countries, the middle-income countries, and the low and lower middle-income countries, on average, the burden is 0.21% of GDP in high-income countries. So you call from the previous slide, across all 11 countries, it's 0.11%. But in terms of high-income countries, it's significantly higher, 0.21% in high-income countries, 0.09% in upper middle-income countries, and 0.04% in low and low middle-income countries. And now there may be a number of reasons why that is the case. For example, the way that kind of women's outputs are valued in high-income countries tends to be higher. The labour participation rate of women in high-income countries or middle-income countries is significantly higher than in lower-income countries. So that's why that figure, that's one of the reasons why potentially that figure is higher. In terms of healthcare expenditures to cover treatment in the first 2 years post-diagnosis was 7 times, 14 times, and 118 times total healthcare spending per capita in high-income, upper middle-income, and lower middle-income countries, respectively. Broadly, the wealthier the country, the less time spent traveling for treatment. Patients in low middle-income countries spend between 45 and 86% of their time, so quite broad range, traveling to receive care, whereas in high-income countries, it's 9 to 13%. Again, some of that may be accounted for in the sense that there are fewer specialist cancer treatments or cancer treatment centres rather in the low middle income countries versus high income countries, and there may be some other reasons. So again, the study didn't really delve into the detail of some of the reasoning behind this, but we do have some commentary in the final published manuscript that talks about the differences which between the high income and low and low middle income countries, and this may be partly attributed to health system strength and access to novel treatments such as those maintenance treatments that I mentioned earlier. And another major factor contributing to the higher absolute burden is this valuation of worker productivity I touched on earlier, in terms of the rates at which citizens are willing to pay for healthcare improvements. So what does this all mean in terms of the things that we are asking for, and what we believe this study is telling us is that it shows for the first time that ovarian cancer is a major burden on broader society, not only disrupting patients' lives, but their social networks, health systems, and the economies. And it's really important to align behind strategies that prevent ovarian cancer. We want to see an encouragement of health system strengthening, particularly in low middle income countries. And there are messages that apply to not just high income countries, and low middle income countries, but all the countries in general. But there are also information and data that comes from the study that really is showing this disparity between the wealthier and the rest in terms of particularly health systems and access to data. So, for example, in low middle income countries, we'd like to see a focus on reliable data gathering. We'd like to see ovarian cancer as part of national cancer control programs, and obviously the WHO being a partner in the study will be part of that going forward. But all countries should identify and treat those women at risk through genetic testing, which we believe is there's a huge opportunity there in terms of identifying women who are at risk, and actually being part of the broad prevention agenda. In terms of the broader aspects of the results, certainly when it comes to support for women returning to the workplace, there should be physical, psychological, and vocational support so that we can increase those return to work rates. And there also should be a recognition of the role caregivers play in supporting women, and a call for counselling and therapy interventions to improve their quality of life. Just briefly, there were some limitations to the study, as there always are with studies of this nature. And again, that's covered in the manuscript, and I encourage you to read that when it's published, hopefully soon. But essentially, the access to data in low middle income countries was something that proved difficult in terms of obtaining data, so that we could have a more accurate picture in those countries. But we did also have the benefit of being able to use the Every Woman Studied Low and Middle Income edition. Just one or two other limitations. So our costing framework minimally accounted for things like emergency hospitalizations and inpatient visits. The informal caregiving aspect, transport costs were included, but things like costs associated with lodging, for example, if you were traveling to receive care, that's not part of this. Or say, for example, childcare costs associated with traveling to receive care, that wasn't part of the study. So the message there really is that the figures that you will see are very likely an underestimate. So that is a synopsis of the study. As I say, we have submitted this to publication, and hopefully we will see this published in the new year. And what we will be doing going forward is working with our partner countries who were part of the study and the WHO to make sure that this is disseminated and that policymakers understand the burden that ovarian cancer is to women and to broader society. And hopefully this will be an agent for change. Thank you.